welcome to Health Matters. I'm Dr. Lynda Young, and Health Matters is a production of the Worcester District Medical Society. We're at WCCA TV, channel 194, so thank you for joining us. Today I have with me Dr. Cynthia Hall. Dr. Hall is an associate professor of obstetrics and gynecology at the University of Massachusetts School of Medicine and the fellowship director in female pelvic medicine and reconstructive surgery at UMass Medical Center in Worcester. Originally from suburban New Jersey, she's a graduate of Wesleyan University and the State University of New York Downstate Medical School. She did her residency at Long Island Jewish Medical Center and her fellowship in urogynecology, we'll talk about that, we'll get definitions on all this stuff, at Harbor UCLA in Los Angeles. She was the founder and director of the Center for Women's Continence and Pelvic Health at Cedars-Sinai Medical Center, also in Los Angeles. One of Dr. Hall's passions is global health, and she's been traveling yearly to sub-Saharan Africa since 2003. She operates on women there who have injuries from childbirth. So welcome, Dr. Hall. Thank you for joining us.
Thank you.
I'm going to ask first thing, what is urogynecology? And what do you do?
Well, I get that question a lot.
I bet.
Yes. Well, it's a relatively new specialty in terms of board certification. And it's basically a conglomeration of gynecology and urology. And it basically works on women's pelvic health issues.
Okay. So what is, I know you had said it's relatively new, and you were the founder of one of the programs in Los Angeles. So what kind of things do you see, and what kind of things do you treat?
So as the name urogynecology implies, it's urinary incontinence is one of our main things that we treat, but also a lot of urinary urgency and frequency, and overactive bladder. And pelvic prolapse, so that's when there's a heaviness or a dropping of the pelvic organs, which also can happen after childbirth. So in this country, for example, we don't see the same types of pelvic conditions that we see in Africa, but we'll see herniations of the organs. And then sometimes it's chronic urinary tract infections and that kind of stuff too.
So what are the pelvic organs?
Oh, so, the pelvic organs are basically in the vagina, or so herniations of the bladder into the vagina, or the uterus down into the vagina, or if you've had a hysterectomy, it can be just the top of the vagina down, and people can experience symptoms of heaviness and fullness, or if it gets bad enough, they can actually herniate through the vaginal opening.
So what does herniate mean?
Sorry.
That's okay.
Well, similarly, like if you have a hernia in your abdomen or around your belly button or in the groin, you may have a protrusion, or you can even experience pain. And it's obviously not the way I describe it to patients is if your intestines are bulging through your belly button area, it's not the fault of the intestines, it's the fault of the abdominal wall.
Yes.
And so if your bladder is falling, it's not the fault of the bladder itself, it's the fault of the vaginal wall that should be holding it in place.
Okay, all right. So that's obviously, it's interesting that there's this new specialty because this has been happening for years. So I'm going to go back to probably one of the more common ones with urinary incontinence. And many women, and young women too, you know, you laugh, I don't know, anything that increases pressure down here, you can have a little accident, so to speak. And I think that's something that can be, it tends to happen more in the elderly, I would imagine, but I'll let you explain what that involves.
Well, it is more common as you get older, but it can be very common in young women after childbirth especially, and in fact, for young women, it is definitely very linked to childbirth. But after the age of 50, it's actually equally common in women that have had babies or not have had babies. Or if you've had a cesarean delivery, it can be equally common, whether you've had a vaginal delivery or have had a cesarean.
Wow.
And we see it in nuns who've never even been sexually active potentially. And so it's exceedingly common. And people sometimes think that it's kind of a normal thing as they get older, but that doesn't mean that you need to live with it.
Right.
And so we have lots of treatments available, it's not always linked to coughing and sneezing and laughing and exercise, for example, but that's one type of incontinence that we call stress incontinence, meaning a stress on the body causes the leakage. And then there's, of course, other types of leakage that occur with urgency, for example. So we call that urgent incontinence. And that's treated completely differently.
Right, right. So let me go back to that first, the stress incontinence, so to speak. And so I'm thinking about when you look through magazines of any kind, you see adult diapers, that sorts of things. So I would think that if you didn't want to have anything done about it, that's what you're faced with, which is not really something that you want to live with, as you had mentioned. So what's the treatment? What would be the treatment?
Well, it obviously depends on what type of leakage you have, but you're right. You can use absorbent pads, and if it's minor leakage, maybe that is all you would like to do. But sometimes you can do something pretty minor, like just alter your behavior. So you can go to the bathroom a little more often that people don't even really necessarily think about.
Right.
Or just, curtail some of your liquids, or there are certain things that a lot of us put in our systems that are bladder irritants. So especially if you've got urgency type leakage, or urgent, or just urinary frequency, things like caffeine, and artificial sweeteners are a bladder irritant. Smoking is a bladder irritant, and alcohol. So those are usually the big four.
Right.
And sometimes people are aware of those things and they've already done that.
Yes.
And sometimes people really are not aware of that. So having people just be aware of those things and saying, we're not here to say you can never have those things, but if you're going to be going on a long car drive, maybe that's not the time to have
Watch
three.
the coffee.
Yeah, exactly. Maybe that's not the time to be having 4 coffees.
Yes.
And then going more frequently, or doing something simple like doing your pelvic floor exercises. There's actually a whole feedback loop, basically from the pelvic floor to the spinal cord, and something called the pontine micturition center, which is the center in the brain and the spinal cord that actually tells the bladder, no, it's not time to urinate right now. It's not time for the bladder to contract, and we call it mind over bladder. And you can actually train your bladder to listen to your brain, basically.
Right, right.
And it's interesting because patients, they're like, wait a minute, you have a name for that? Because we have something called key lock incontinence, because patients, as soon as they pull into the driveway and as soon as they put the key in the lock,
yes,
their bladder immediately knows they're home.
Yes.
Because their brain knows they're home.
Right, right.
And they start running to the bathroom, and they're leaking on the way to the bathroom. And they're like, really? Other people have that too? Oh, yes.
Oh, my.
It's a very common phenomenon.
Yeah. So how, let's say the bladder irritants and such, if that's a concern and you either avoid or drastically cut down on those things, how long does that take to make a difference?
Well, if it's just the irritant thing, that you can see a difference almost right away.
Okay.
But if it's something like doing your pelvic floor exercises, that can take longer.
Okay.
And so I'll often, if I have a patient come in and we're talking about irritants and just time voiding, they might be able to see a difference very quickly within days to even weeks. If they're doing pelvic floor exercises or actually training their bladder to hold more and more, which you can also do because your bladder can kind of get used to having so little in it that it doesn't really hold very much anymore. That may take more like 6 weeks or 3 months. And we actually have pelvic floor physical therapists that will work with you if you don't know how to do your Kegel exercises.
Yes. Can you briefly explain what those are?
Okay, so basically, Kegel exercise is actually squeezing the vaginal muscles. So the way we usually explain that, and I'll actually, when I see a patient in my office, while I'm doing my pelvic exam, I'll push on the muscles and ask the patient to squeeze their vaginal muscles around my fingers. And some patients think they're doing them correctly. They'll be like, oh yeah, I cross my legs and I squeeze, but they might be also squeezing their abdominal muscles and pushing down, or they might be only squeezing their buttocks, or they might be doing them completely correctly.
Right, right.
And we know actually from studies that 50% of women do them correctly, and the other 50% are not doing them correctly. And actually, of that 50% that are not doing them correctly, 25% of them are actually pushing. So they're actually doing the exact opposite of what they're supposed to be doing. So that's why it's kind of important to make sure they are doing them right.
Right.
Because they can actually be doing more harm than good.
Yes.
And so, basically I usually describe it as, try to use the muscles you would use to hold back gas or hold back urine, or lift your pelvic floor, or pull in your coccyx, your tailbone. And then usually with a little guidance and also by pushing on the muscles, you can get a sense of whether somebody's able to do it and how strong their muscles are. And sometimes even just with a minute, I can get an improvement.
Yes, yes.
And if somebody's doing them correct, then I usually send them home doing them on their own.
Right.
There are actually home biofeedback units now that input into your smartphone and actually show you how much better and stronger you're getting.
Oh my!
Which is wonderful because
yes.
If you go to the gym, you know how you don't see that you look better within a week or two.
Right.
So it's hard to kind of keep up with it. But if you see that you're getting stronger, you may stick with it for long enough until you see that you look better.
Yes, yes.
So it's kind of inspiring. So those biofeedback units see that you're getting stronger, so I think people are more likely to stick with it. And then if somebody's not able to do it, you can send them to a physical therapist, and it's usually covered by insurance. And of course, the physical therapist, because they work with similar patients, they can put you on a timed voiding, and they can give you other tricks that have worked for other patients, like if you look at the toilet and that's what triggers the urgency, then don't look at the toilet, or count backward from 100, or other little distraction things that have worked for people.
Yes. So I love hearing this because the first thing you think about is, oh no, I need surgery now because so and so had that and she had to have surgery. And I know that's an answer, but these are great ways to say, this may well work.
Right.
So don't avoid it. Just try to do something about it. So.
Well, and I would say that, especially. I work locally, and me and my two partners here, we get so many referrals from patients that either have mild leakage or, they have already told their PCPs, their primary cares, that they really are not interested in anything invasive. They're not interested in medicines. They're not interested in surgery. And yet the primary carers have encouraged them to come because they know that we never push anything on a patient. We know that patients are, going to feel empowered because we allow them to make their own decisions about their care.
Yes.
And we just kind of lay it all, well, here are the options, and don't be discouraged, and it's really up to you.
Right. What's the danger of just sort of living with it, other than the discomfort?
There really is none.
So there aren't more risk as far as urinary tract infection, anything like that?
There's some data to suggest that if you're soaking wet all the time and wearing an absorbent pad, and you're sitting in the wetness all the time, that maybe there's a slightly increased risk of urinary tract infections. But often those patients have other multiple medical morbidities. They're sicker patients often. And so that probably has more to do with the chronic urinary tract infections than the actual incontinence does.
Yeah.
So probably not.
Okay. Oh, that's interesting.
Yeah.
So I'm going to take us a little further down the road. Let's say none of that works, or it worked for a while and now it doesn't work anymore. I'm assuming you're a surgeon. So I'm assuming that there's a surgical answer. Can you explain what that is?
Well, so first of all, it depends on what kind of leakage you're talking about.
Yes.
So if we're going to talk about potential surgeries, we're usually talking about stress incontinence, so the coughing type leakage. First of all, if you've already done the pelvic floor exercises and they haven't been successful, there's a non-surgical option first, and that's something called a pessary. And I should have brought in my little pessaries because I usually have my lab coat on. I whip out a little pessary from my pocket, which is a silicone device, and some of them have metal in them too. But this is something that the patient can manage on their own, or if they're not interested, we can manage it for them. And this is a vaginal device that we individually fit for the patient. And it's something either they can take in and out of the vagina on their own, or we can manage it. And that means that they would come to the office and we would take it out and clean it off and put it back in every 3 months. And so this is something that goes in the vagina to support the urethra, because the vast majority of women, especially young women, that have stress incontinence, it's because of a lack of support to the urethra. So it's an anatomic problem, which is why surgery works.
Yes.
Because it's an anatomic structural solution. And so what it does is it gives support to the urethra to basically prevent mobility of the urethra so they don't leak anymore.
So the urethra is the little tube from the bladder to the outside.
Yes, and I usually, what I do with a patient is I actually, I have these big pink sheets of paper that so they can find them. And I do a little drawing showing them that the that here's the bladder and here's the urethra and here's a side view of the female pelvis. Here's the pubic bone, and these pubourethral ligaments are trying to close the urethra every time you cough or sneeze. But if the urethra is mobile, they can't do that. And so by squeezing those muscles, you're trying to keep that urethra fairly stable so that you don't leak. So the second option is putting this pessary in that supports the urethra so you don't leak. And that works actually even if you're leaking pretty bad. A lot of the time, we don't know whether it'll work, but it's always worth a try.
Right.
So if it doesn't work, what have you done? You just spent a little time.
Right.
What's the big deal? Or if you don't like it, or even if you know you want surgery, but you don't want to do it over the summer. So you want to get through the summer, and maybe in the fall you'll have surgery or whatever.
Right. This is totally, I'll have it when I want it.
Exactly.
It's not an emergency.
Exactly. Exactly. So that's option number 2. And I write this down. Option 1, Kegels. Option 2, pessary. Option 3 is surgery. And we have multiple different surgeries that we can do. But the surgery that most women choose at this point is what we call a mid-urethral sling, which is made of this polypropylene mesh, and I say that right out of the gate. Yes, it's the same type of mesh that we use. You see the lawyers on TV. They say mesh is the worst thing ever, but mesh is your friend. It allows us to do a minimally invasive surgery that where the mesh goes around the urethra to support the urethra, like you put your hand in a sling. This is a mid-urethral sling that puts your urethra in a sling to prevent you from leaking because it supports the urethra. The old way we used to do surgeries, you'd have to have an incision where we would basically support the urethra with sutures, or we'd actually have to make a sling out of your tissue or from tissue from a cadaver from a patient who's died or an animal. Where we'd make the sling, but still you'd have an incision, and so your recuperation time would be basically 6 weeks where you'd basically be hurting and your recuperation would be slower, and you might have voiding dysfunction and not be able to urinate for up to a few weeks and need a catheter. And that's fine. We can do it that way. But with the mid-urethral mesh slings, you'll be basically able to exercise within a week. You should have minimal pain. Most people can go back to work within a few days. And it's really revolutionized our treatment. And we've been doing them that way for 20 years.
Yes.
The FDA has not recalled the slings at all. They very clearly say vaginal mesh is one thing, mid-urethral slings are something completely different.
Yes, yes.
And then I usually tell them that I have a sling myself, and they often are very,
And I think it is important to make that distinction because
Yes.
that's what you hear about. You hear mesh and you think, oh, I don't think
And
that's so good.
I have a piece of mesh on my coat, and I let them feel it.
Yeah,
And
yeah.
so, and I invite them to look it up basically on.
And so that would be a one-time surgery. Would it need to be repeated?
Possibly. So we have good data to show that the success rates after like 2 years, 1 to 2 years, are equivalent at, say, 7 years. Hard to do studies that follow women longitudinally for a long, long, long time because patients get lost to follow-up.
Yeah.
Either they're doing really well and they don't want to come for follow-up, or they're not doing well and they don't want to come for follow-up. It's just hard to get a very good, 85% follow-up rate after, even a few years. And so we have a good sense that they last. Certainly the material is a permanent material.
Mm-hmm.
But what I usually tell very young women who have very mild incontinence is don't necessarily to jump to surgery immediately. It is a very easy surgery to come to, but if you're 35 and you've only mild leakage, only with certain activities, it's only once or twice a week or something like that, you might think twice because you might very well need a second or third sling in your lifetime.
Sure.
And we do know that this second sling may not be quite the 85-90% success rate that it is. It may be a little lower than that. Now, do we take the old sling out? No, we do not. We reassess, and if you need another sling because it's a hypermobility of the urethra problem, we would just put a new one out. So it's still not a major procedure probably, but you do need to think about it.
So that's one of the major things that we wanted to discuss today.
Yeah.
What are some of the other conditions or issues that you see also and obviously this is just in women?
Right, exactly. Right. I'm a urogynecologist,
Yes.
so I just treat women's incontinence and prolapse. So prolapse is the second big category that I treat. So that's basically when any of the organs are falling. So that can be, or bulging, we should say. So the front wall of the vagina can be bulging, which is called the cystocele, that's the bladder. Or the central area, which is the uterus, or the rectum can be bulging. And when any of those things are falling, the woman can be very uncomfortable. It can be, she can feel bulging symptoms. She might have difficulty urinating. She may have difficulty defecating. She may have sexual dysfunction, oftentimes not. Or she might just feel something there and be very concerned. And so basically we have the same type, she needs a very full examination, usually by a specialist. Unfortunately, a lot of times, certainly primary care specialists, but even general OB, obstetrician gynecologists are not able to distinguish, oh yes, definitely it's this organ, it's an anterior wall defect, it's a central defect, it's a posterior defect, and address all of those things and do the appropriate evaluation and corrective surgery if necessary, and correct those things surgically. So we do surgeries for those, or fit a pessary. Pessary's worked for that too. Or maybe it's hands off. She doesn't need, maybe she's not bothered by such things.
Is it dangerous to let that go?
Usually not, unless somebody's not emptying their bladder,
Yeah.
and they're getting recurrent bladder infections from not emptying their bladder. That sometimes can be an issue. Or if it's bad enough, it can even kink the ureters, which are the tubes coming down from the kidneys, and back up into the kidneys. But that usually it's bad enough at that point that the patient's really bothered by it.
Yeah, I would think. Whoa.
You'd be surprised, but
you never know.
Yeah, you never know.
Okay, and other conditions at all? How about like defecation problems, incontinence with that?
We do see a fair amount of that, difficulty with defecation. And one of the most important things to talk about at that point is, are we talking about hard stools, or are we talking about trapping of stools? And so I have daily conversations about constipation and the need to take fiber on a daily basis. people say, well, but I'm making sure I'm eating my vegetables and stuff. On like the daily fiber requirement is way too much for you to really meet your daily fiber with diet alone, especially in the wintertime when there's not a lot of fruits and vegetables available. And so I usually recommend Metamucil as first choice because it has benefits with stabilizing your daily your sugar, and also keeps your cholesterol levels down.
Sounds good.
Yeah, exactly. Has many benefits. And then the other thing is that our toilets keep getting taller and taller and taller.
They do.
And I am a big proponent of the squatty potty, or at least a stool that will elevate
give you
your
some
knees.
leverage. Yes.
Yes, absolutely. And if you watch the YouTube on squatty potty, it is so funny. But it really explains why keeping your knees elevated really opens up the back angle of the anorectal angle and allows things to evacuate.
So we are almost out of time. We have a minute to say, or 30 seconds or whatever, to say what's your big take-home point?
My big take-home point really is that pelvic floor problems are a quality of life issue, and you don't need to live with them, and you should discuss it with your primary care person, and if need be, come and see us, or the specialists that can help you with these things, because we will not be pushing anything that you don't want to do, and we're here to just help.
Great, great. Well, thank you very much.
I
like you don't have to do this, and there are other things to do. It doesn't, you hear that, oh, she must be a surgeon. Oh, that means I have to have surgery. And it's so nice to hear there's a lot of other issues that you do not have to have this. If you want to, you can have it, but you don't have to.
Absolutely.
So I think that sounds great. Thank you.
Thank
you very much. And thank you very much to Dr. Hall for joining us. This is Health Matters from the Worcester District Medical Society. Thank you for joining us, WCCA TV, Channel 194. Thank you. So we can just sit and talk.